time now for the next session. And may I now invite the next set of chairpersons, Dr. Aparna Deshpande and Dr. Rudra Acharya, who are already there, logged in. Please take the proceedings further, Dr. Rudra.
Yes.
Thank you so much.
Yeah, good afternoon. I think we will be going with the today's proceedings. These are a group of videos that are being short videos being is to be presented. And Dr. Aparna is already there?
Yes, I have joined.
Yeah. So I think the first video is by laparoscopic splenectomy, Dr. K. Senthil Kumar.
Good evening, everyone. Hello.
Yeah.
Dr. Senthil.
Yeah, good evening, everyone. First of all, I thank the organizers for giving me the opportunity. Are you able to see the screen? Have a slide?
Yes, we can see.
Yeah, thank you. So I'm going to talk about the procedure laparoscopic splenectomy. Mostly we go with anterior approach. The patient is 45-degree left side up tilt, and we have to adequately support the patient with the pillows and straps. And we have to keep the monitor on the left side of the patient. Surgical team is on the right side of the patient. And pneumoperitoneum we used to create with Virus needle, and camera trocar is inserted about 5 centimeters above and onto the left of the umbilicus. It depends upon the size of the spleen. Sometimes if the spleen size is more, very large spleen, we may need to shift it close to the midline. And the first step is we have to divide the splenocholic ligament, and then we have to go up dividing the gastrosplenic ligament. While dividing that, we will be dividing the short gastric vessels. And once it is exposed, because of the position of the patient, the stomach will fall away from the operating field. And we have to identify the splenic artery at the upper border of the pancreas, and it should be dissected adequately. The arterial inflow has to be controlled as the first step, because if you do that, the size of the spleen will come down, and it will in fact reduce the bleeding during the surgery. And the splenic vein is dissected. Next is the splenic vein dissection, and we have to control with the ties and endo clips. We can use staplers also, but we use ties and clips. And for the splenorenal as well as splenic ligament should be divided as the last step, because with the position, the tilt, lateral tilt, if you divide it at the beginning, the spleen will fall onto the operating field, and you will have some difficulty in exposing the splenic artery and vein. And specimen can be retrieved by putting into endo bag through extended incision, or you can remove it by fen and steel incision if you want to remove the spleen intact without crushing it. And I'll just show the images of this the procedure. This is the patient position. You can see patient is more than 45-degree tilt, and we have supported with pillows. The arms are supported, and even in between legs we have kept a pillow. And this is the port position, and you can see a final fen and steel incision. Because this is a large spleen, we removed it without in total. And this instrument, the lateralmost instrument, which comes from the anterior axillary line, it takes the spleen towards the lateral wall, so that it will expose the hilum of the spleen beautifully. And because of the gravity, the stomach will move away. Once you divide the gastrosplenic ligament, the stomach will move away from the operating field, and it will give a beautiful exposure to the. This is the gastrocolic omentum, which you can divide it by using ultrasonic CS. And as you go up, you can see the lesser sac, and as you go up, we'll be dividing the gastrosplenic ligament as well as the short gastric vessels. And once you do that, then it will expose the entire lesser sac and the splenic artery as well as the splenic vein beautifully. And this is the division of the lowermost attachment from the spleen to the colon. So the colon also, the splenic flexor of the colon will move away, and the stomach also will move medially. And other important structure which we have to be very careful and worried about is the tail of pancreas that should be identified by releasing all the attachment between the stomach and the pancreas completely lysed, so that it will expose the pancreas beautifully. This I can appreciate the tail of pancreas nicely exposed, and you can appreciate the splenic artery lying on the upper border of the pancreas. So this is the first step. You can appreciate that we are actually splenic artery. Everybody knows it has got a tortuous course, and we just ligate the splenic, dissect the splenic artery, and this is the splenic vein which is dissected. Sometimes you can ligate and divide the splenic artery, and you can go all around and divide the attachments except the spleno-renal as well as the splenophrenic attachment, and finally you can ligate, so that during that waiting period, the blood from the spleen will get drained, and even the spleen will become much smaller. So this is the ligated and divided splenic artery and vein. You can see the upper border of the pancreas. You have to trace the upper border of the pancreas, and you just go up to the tail and preserve it from injury. This is after division of the artery and vein. You can appreciate there is a color change, and this is the attachment that you can appreciate the pancreas. It's very closely related to the splenic artery vein as well as the splenic hilum in few of the cases that should be carefully identified and protected. You can see the pancreas. This is completely divided hilum, and you can completely lysed. All vessels are divided. Then only you have to go and remove all the attachment between the spleen as well as the kidney as well as the spleen and the diaphragm attachments. So this is the final step, so that the spleen will not come and fall onto your. This is the attachment between the spleen as well as the diaphragm. So you can see the completely detached spleen, and this is a perfect hemostasis. You give a nice wash, and if necessary, you can put a drain and come out. So if a proper plane is maintained, then absolutely there will not be any blood loss. This loss also from the backflow from the splenic vein, not from the dissection site. So this is the Fenton steel incision through which we are removing the spleen in toto, and sometimes if the spleen is moderate size, you can appreciate it is extending from the xiphoid process to the almost to the pubic symphysis when it is placed on the interabdominal wall, and it is 23 centimeter in length. The spleen, this spleen is 23 centimeter in length. This you can appreciate. This is the port which is coming from the lateral part of the abdomen, mostly on the anterior axillary line. This, if you introduce a 5 mm grasper, toothed grasper, and gently retract the spleen onto the lateral side, and if you grasp the instrument to the triangular ligament, left triangular ligament, it will remain there itself without any disturbance until the end of the procedure. So you just use a 5 mm instrument. You just take the spleen onto the lateral side and grasp it with the triangular ligament, and you just leave it until the end of the procedure. It will not have any disturbance for your dissection. And then the first step is going and opening the gastrocolic as well as the gastrosplenic ligament. This is a very nice instrument, and if this harmonic scalpel is very useful, and if you divide it, absolutely it is a bloodless field. And as soon as you open the we divide the gastrosplenic ligament, you can appreciate this is the pancreas here. Immediately you can notice the pancreas, and on the upper border of the pancreas you can appreciate the splenic artery which is lying here. So this is the first step of any splenectomy procedure. This positioning of the patient is very important. That only actually helps. Sorry, so the positioning is sorry. So it's coming again and. Once again, I will put the other video.
Dr. Sendil, don't start sharing before the video runs.
Yeah, video runs actually. Now it is running.
Okay, but we are not
I'll
able to see that.
Yeah, one second. Yes.
Yeah, now I got it.
Okay, fine. Thank you. So this is the procedure. So now we can see that we are actually, this is the upper part of the pancreas. We are trying to dissect the splenic artery. This is the splenic artery which we are dissecting. And there will be some branches which is coming from the splenic artery to going to the pancreas, which can be actually divided. And this is the splenic vein, which we are dissecting it carefully. And we will be ligating with at least 2 or 3 sutures on either side, and we will put clips also. So this is the splenic vein which is being dissected now. And whenever we ligate a splenic vein, we have to ligate it proximally. The flow, you should, we know the flow, direction of the flow, and the ligation, the first ligature should be applied on the proximal side. Then only, otherwise the splenic vein will get distended. Here also you can appreciate we have put 2 ligatures here, and the vein is distended now. Then the third ligature, it is very difficult. So whenever you want to ligate it, first ligate it here, and then do other ligations on the distal side. The flow is from here, this direction. So you have to always proximally ligate, then come distally. So already we have done with 2 ligatures. Artery has been divided, and we are dividing the splenic vein. And then once it is done, then what remains is only releasing a division of the lateral attachments, which is very easy. And we can go and divide all attachments to the kidney as well as to the diaphragm. And then finally, if the spleen is large, then sometimes we use phalangeal incision. If it is a medium sized or a small spleen, then you can appreciate the pancreas very close to the splenic vein, and you can appreciate the pancreas. That pancreas needs to be protected. And once it is, then we will remove. This case we remove by using a phalangeal incision. Thank you very much.
Thank you, Dr. Sendil.
Thank you.
It was a wonderful.
So questions are allowed?
I think
so just one question, Senthil, have you sometimes required a vascular stapler for the splenic vein?
Yes, sir. We actually keep the stapler by the sides. For that, we have to completely identify the structures, hilar structures, and completely isolate the vessels before applying it, because sometimes accidentally, if you apply it across the tail of pancreas, that may create a problem. So isolate the artery as well as the vein, and you can fire a stapler across. That is also actually it reduces the time, and it's very useful sometimes. Especially if the vein is very large, we can use the staplers.
Thank you.
Very large spleen. Thank you, sir. Thank you very much.
Thank you, Dr. Sendil.
Dr. Aparna can take over.
Again, nice video. Any role for morcellator? Do you use morcellator at any time?
No, actually we put the spleen into bag, and we'll take the spleen outside through one of the extended port. Then we use the sponge holding forceps to fragment it into multiple pieces, and we will take it out. We will fragment mechanically by using sponge holding forceps, and we will remove piece by piece.
Yes, I think that is a more practical way of doing it, so you can avoid the morcellator also. Thank you, Dr. Sendil. That was
Thank
nice.
you. Thank you very much. Thank you.
I think the next video is for laparoscopic left lateral segmentectomy by Dr. Nilesh Doctor.
Yes, I have started screen sharing. Can you hear me?
Yeah. You are
And
completely audible.
Yes.
And the screen is...
Welcome, Dr. Nilesh.
Thank you very much. I thank the organizers for requesting me to speak on this topic. It's a little strange that there are two different types of liver resection, quite different from each other. I'll try and cover both of them in the short time provided. Are you able to see the screen?
Yeah, we can see.
Yeah. So the first
screen is visible. Can you please play the slideshow so that we can get it on the full screen?
So this is a gentleman who was otherwise fit, post chemotherapy status, post APR, and a single metastatic solitary lesion in segment 2 and 3 of the liver. So you can see that was a PET CT report of this patient. And as you know, there are several options of treatment, and for colorectal liver metastasis, the best option is to resect them. Even secondary re-resections, etc., provide survival benefit to these patients. And this patient had a single metastatic lesion in the left lateral segment and was planned for a laparoscopic left lateral segmentectomy. So the steps are, I'll just go through the video and show you these steps. Essentially, division of the falciform ligament after inspection of the peritoneal cavity, left coronary ligament, inflow and outflow control, transection plane developed and before the transection, intraparenchymal ligation and division of the left portal pedicle to the segment 2 and 3, and intraparenchymal ligation and division of the left hepatic vein, hemostasis and bile leak control. So this is the video. So you can see the port positions in the video that we have placed, and you can see the left lateral segment visible through the port. And our first steps will be to do an inspection of the peritoneal cavity and then start division of the falciform ligament. Go up right up to the IVC, mobilize the left lobe. It's the exposure of the middle and left hepatic veins and followed by the porta dissection. So you don't need a formal porta hepatis dissection in these patients because you're going to take the portal pedicle intraperitoneally. Here we are just isolating the porta to, so here what we do is we use an open vascular clamp as a porta clamp, just like how you introduce a clamp to retract the liver during fundoplication. We use a small 5 millimeter incision to introduce a porta clamp for intermittent outflow occlusion, inflow occlusion. And here you can see the dissection after the arachis ligament of the dissection of the outflow, and we control the outflow and then plan our transaction. So we have established both inflow and outflow control, and our transaction we do initially with a tonic and then proceed to doing it with a, after the first 1 or 2 centimeters in the superficial capsule, we use a laparoscopic CUSA for transection, and this makes it very easy to see the small hepatic veins and do intrahepatic ligation of the various vessels. So all the smaller vessels, as you know, with the CUSA suction aspiration, you can clip the small vessels as you go along, and till you come to the large pedicle where the portal pedicle is clipped with hemostatic clips, and the biliary radical is also clipped with the hemo clips, which are self-locking clips. Finally, you can see after the specimen has been completely separated, clipping of the hepatic vein right at the top. So total surgery time was 200 minutes approximately, with a clamp time of 22 minutes, and intraoperative blood loss was not very significant. And the recovery was in the ICU for a day. Brain was removed on post-op day 2, and the patient was discharged on the 4th post-operative day. Laparoscopic right posterior sector excision is a little more tricky because here I'm showing you a patient who had a symptomatic hemangioma in segment 6 and 7. You can see the CT of the same patient here. In fact, one of the other reasons was that it was not a classical hemangioma, and there was some doubt as to whether it could be something else. It was about 12 centimeters in maximum diameter. So similar inspection of the peritoneal cavity and position of the patient. So you can see here port position. So that's the position of the ports. It's quite it can be a difficult operation because you're dealing with the position of the tumor in a very posterior location. And in fact, there are several reports of a transthoracic approach to excise these two segments. So here you can see the first step is to start off with so after mobilization of the, you can see the lesion there. And after mobilization of the lesion from the diaphragm laterally, we do extrahepatic control of the right posterior portal pedicle. After achieving control of the inflow, you can see here that we are trying to dissect the right posterior pedicle. So after the bile duct is been pushed forward, you can see that the main portal vein is seen now. The bile duct will be retracted anteriorly. You can see the retraction of the bile duct, and then the portal vein and the portal pedicle is being dissected along with the right hepatic artery. So here you can see that for further dissection of the main portal vein and the right branch going into the right anterior and posterior branches, we would be able to, we would have to divide the liver to do that. So after encircling the right hepatic artery for control, you can see that the next step involves the dissection of the right portal vein. So for that division of the right portal vein, it is important to do a small hepatotomy, and the hepatotomy will be able to help us in dissecting the branches of the right portal vein, the right anterior and posterior portal vein, so that you only take the right posterior portal vein prior to. So here you can see the dissection of the right portal vein into its right posterior branch and right anterior branch. So once you have confirmed the presence of you ligated the small branches which are coming in from the right anterior and posterior portal veins, you'll get a length of right anterior and posterior portal vein. So once you get an adequate length of the right posterior portal vein, you will be able to divide it and transect it. So here you can see the final dissection and encircling of the right posterior portal vein. So once that has been clipped, you will be able to then follow the branches of the artery inside the liver and clip branches to segment 6 and 7, following which you should be able to see the transection line of the right posterior sector, which is the segment 6 and 7. Here you can see that the camera is one of the important things to note here is the camera position. The position of the segment 6 and 7 line is very much laterally. So it's very important to mobilize the entire right liver so that your transaction line is visible from your anterior port. Otherwise, you land up operating at a very odd angle and you will not be able to see. Here you can see that you are operating at right angles, even though the right posterior sectoral line is very much lateral. So it's a combination of both mobilization of the right lobe plus right placement of the camera port. So as you can see here, the further dissection goes on. Here we have not taken the main right hepatic vein extrahepatically. In the right posterior sectorectomy, it is sometimes difficult to actually get the right hepatic vein dissected extrahepatically, and we will see the right hepatic vein intrahepatically, as you can see, being stapled here. And the segment 6 plate structures are transected using a parenchymal stapler, and right at the end, you will see a stapler being used for the right hepatic vein branches from segment 6 and 7, and not necessarily the main right hepatic vein, which also has tributaries from 5 and 8. So it's completed, and then the specimen can be retrieved from either a phalansteal incision or a lower abdominal incision or a vertical incision. Now, there is some evidence to suggest that a small vertical incision is probably less painful than a transverse incision, unless you're using a phalansteal incision in a female patient. So that's a completed right posterior sectorectomy. It's a much more difficult operation than a left lateral segmentectomy. Intraoperative blood loss is a little bit more. Patient was vitally stable with no problems, and the ICU recovery again for 24 hours. Drain was removed on postoperative day 2. It was discharged on postoperative day 4 with a good functional recovery. Thank you. So I've tried to show both the procedures in a short period of time. So if there are any questions or comments, I would welcome that.
Nice presentations, Dr. Nilesh. I think left lateral segmentectomy can be considered now as a standard of care, but the posterior segmentectomy is much more difficult. So how would you advise proceeding in laparoscopic liver resection?
Yes, I think that's a good question. I think unless you've done many open procedures to begin with, it's only after you've done many open procedures you'll be able to start doing lap. And I think to start off with a lap left liver resection or even a left hepatectomy or a left lateral segmentectomy is much easier because you don't need to do much right lobe mobilization, and the angle that you're operating on at is angle we are familiar with. So it's very important to give the proper position and a proper port position. After you've done about at least 8 to 10 left segments, you should start doing a right hepatectomy.
Thank you.
Laparoscopically.
Thank you, Dr. Nilesh.
Thank you.
Thanks a lot.
Thank you very much.
We will go to the next master video now, spleen preserving laparoscopic distal pancreatectomy by Professor Baiju Senadipa.
Welcome, Professor Baiju. Now he is more famous by the Senadipan Education Foundation, doing so many high quality webinars. So welcome for the video.
Yeah, thank you, Dr. Rudra Acharya and Dr. Aparna for this opportunity. Thank you, IAGES and UK Surgical Forum. I've been asked to present a spleen preserving laparoscopic distal pancreatectomy. Going through the indications, you all know that the serous steatocystoma, mucinous steatocystoma you can do spleen preservation. Non-malignant peanut probably, but you will have to evaluate the patient thoroughly before going for a spleen preservation. Focal pancreatitis indicating surgery is another indication for a splenic procedure. Advantages you all know: reduced septic complication, reduced hospital stay, and the contraindication. It's contraindicated malignant tumors, solid pseudopapillary tumors, because the malignant potential is contraindicated. Neuroendocrine tumors, if it is well evaluated, you should avoid a spleen preservation. Actually, the interest in spleen preservation came forward because the publication by Kimura Group in 2010. They preserved splenic artery and vein in their technique. Actually, that was the recent enthusiasm regarding splenic preservation. There are two methods. One is Kimura's method, and the other one is Varsha's method. In Kimura's method, as I said, the splenic artery and vein is preserved, and the supply to the spleen is depending on the artery and vein only. But in Varsha's method, you are dividing a segment of splenic artery and vein so that the supply to the splenic spleen is by the short gastric vessels. Now I'm going to how I do Varsha's procedure. I'll be telling you the port positions later. So this is actually a benign tumor in the distal part of the pancreas. You will have to open the lesser sac like this by using harmonic scalpel. You can keep a pillow on the left side of the leg to back of the patient so that you can elevate the left side of the patient so that when you give a tilt, that will be exposing the splenic hilum. Now, once the lesser sac is open, you will have to mobilize the posterior aspect of the stomach and exposing the pancreas fully. Now we can see that the flimsy layers of attachment from the posterior surface of the stomach to the pancreas is taken care. Now you can see that the pancreas is fully exposed, and you can see the spleen here. Now that is the tumor which is has to be removed. Now coming to the lower part of the inferior body of the pancreas, it's the attachment of the mesocolon is attached. This is the DJ flexure. What you are seeing is the DJ flexure that is taken down, and further mobilization of the just lateral to the capsule of the pancreas is taken down with the harmonic scalpel. Now there must be a vessel which is coming from the inferior mesenteric vein joining the splenic vein. That is, you can see the splenic vein here. That is the inferior mesenteric vein. Sometimes this will be having an oblique course and join the confluence. Here it is not join the confluence, but it is join the splenic vein only. So that is also taken care. That depends on whether the tumor is in the proximal body or distal tail. Now you are going superior to the pancreas. At the superior border of the pancreas to expose the splenic artery. Usually you expose the splenic artery at the superior border, expose the splenic vein at the lower border. Now the task is that in Varsha's procedure, you will have to ligate the splenic artery and vein short of this thing, because the short gastric vessels are coming and joining the splenic vein. So you'll have to ligate the splenic artery and vein distally short of the short gastric vessels. Now the pancreas is mobilized. You can see the short gastric vessels are joining the splenic artery. So it's taken care before the joining. So it is ligated with the ligatures. Splenic vein is now taken care. So you'll have to have a distance at least 2 to 3 centimeters from the hydra itself. Now proximally the vein is ligated, artery was ligated earlier. So at the two sides you will have to ligate the splenic artery and vein. One is proximal, one is distal. And segment of splenic artery and vein is taken in Varsha's procedure. Now the pancreas is delineated at the level of the resection. With endo-GA, it is resected. The choice of endo-GA depending on the bulk of the pancreas. And you can see that the spleen is taken, still the spleen is having blood supply. The pancreas is taken, still the spleen is having blood supply. Now, this is not required. Actually, we are not doing it nowadays. The reinforce of the staple line. Initially, we used to do with 30 PDS. Now you can see the spleen, which is beautifully having supply from the short gastric vessels. Now coming to the Kimura's procedure, the port position, I told you that it's almost same for Varsha's procedure and Kimura's procedure. These are the port positions. Actually, you'll be keeping a wedge on the left lateral side. Kimura's procedure, you are keeping the artery and vein along with the spleen. Now opening the lesser sac. As it was done in the previous surgery. Here, that is the tumor which you like to remove. It is taken, the attachments are taken down to the harmonic scalpel. That is the pancreas exposed fully. Now you have to identify the splenic artery in the superior border. Usually the artery is identified in the superior border. Vein is identified down. And now that is the artery. So the thing is that there will be the branches from the splenic artery to the pancreatic parenchyma. The first artery is called the artery of Arnold. And that is taken care. It's better to take it with that is taken the biopsies for sampling the lymph node and is exposed throughout. The artery and veins are exposed throughout. Now the attachments from the artery to the parenchyma are taken care with the harmonic scalpel or with the clips. Now coming to the inferior part of the pancreas. That is the tumor which has to be taken out. Here we will see the inferior mesenteric vein joined. That is the inferior mesenteric vein joined in the splenic vein. This tumor is fully mobilized.
Sir, can I fast forward because time is short?
Yeah. That is the artery tributaries from the vein, and the artery is taken care. That is the artery. Vessels are taken care. Artery is mobilized again. Now you can see that the artery is lying like a snake there. Vein is same way, the vein is also taken care. You can see the tributaries going to the parenchyma. Another tributary going to the parenchyma, that is taken care with the harmonic.
Dr. Baiju, can you please finish it off fast?
Yeah, finished. I'm finished. This is the artery and the vein.
Correct. Now do the transaction in the same fashion.
Yeah. That is transected. We can see the artery and vein like that. That is the Kimura's. There you can see the supply of the spleen.
Yeah, that is very nice actually, and I think very nice demonstration of both the procedures, and the videos were also very good. I think this is a very good learning for the beginners because both the procedures are demonstrated very nicely. Due to shortage of time, we are not entertaining any questions. We are going. Thank you, Dr. Baiju. We are going for the next talk by Dr. Krishna Mohan from UK on liver transplantation. Dr. Krishna, please.
Yeah, so just one announcement, Dr. Rudra. The plenary session has been revised from 6 p.m. to 6:15, 6:15 p.m. So we have 15 more minutes, and the debate, obviously, as we understand, is getting delayed. So we will after this. This is about 5:25 at the moment, and after say between 5:35 and 40, we shall start the debate and finish the debate by 6:15 p.m.
Okay. Okay.
Okay. Right. Can you guys see the screen? Good afternoon, everyone. Firstly, thank you, Rajesh, Aparna, and Dr. Rudra Acharya for inviting me to this fantastic congress across the continents. And it gives me great pleasure always to see and learn from other people, and I've enjoyed the videos that I've seen today. So my talk is today going to be on laparoscopic hepatectomy in chronic liver disease. When you talk about laparoscopic hepatectomy in chronic liver disease, essentially what you're talking about is laparoscopic hepatectomy for primary hepatocellular carcinoma. And when you talk about primary hepatocellular carcinoma, again, most of us follow the BCLC staging. And when you talk about resection, you're talking about very early stage or early stage HCCs. And this is the seminal paper that came out from Lovett and his colleagues in the Lancet. So what is the key determinant that decides whether or not you should go for resection or transplantation? And the key determinant is actually the presence of portal hypertension. So if there is evidence of portal hypertension, then you tend to go down the transplantation route. If there is no clear evidence of portal hypertension, then you probably go down the resection route. So what are the key principles when you talk about laparoscopic hepatectomy in chronic liver disease? And I think I'm going to dwell a little bit on this because it's extremely important, although it's a technical session. So the most important thing to remember is when you talk about chronic liver disease and resections, you're talking about either doing it in a non-cirrhotic liver, perhaps a fibrotic liver, or a cirrhotic liver where the patient's got good synthetic function and is Child's A with no significant comorbidities. The pressures, the portal pressures, you'd like them below 10. If you're in doubt with regards to the texture of the liver, then you can do a non-lesional liver biopsy that will guide you whether or not the patient will tolerate a hepatectomy. You have to have a clear surgical strategy in terms of resection. There should not be ideally any evidence of known microvascular invasion or metastatic disease outside the liver. When you talk about liver resection in a cirrhotic liver, the extent of resection matters. And it's very important because the reserve might not be there for the patient to recover if you do a major hepatectomy with decreased functional reserve. Sometimes an ICG clearance can be used to help you guide as to whether or not this is possible. The principles in terms of the technique for a laparoscopic hepatectomy in chronic liver disease are understanding the preoperative radiology. Plan very carefully what you're going to do, anatomical or non-anatomical. You should be able to use a laparoscopic ultrasound and get used to doing this well, because there is not going to be any other way of you knowing your way around good anatomy. I always use a Pringles maneuver. I have the tape around. I may not necessarily occlude the hilum, but you have to have the tape around, because when you run into bleeding, that is the worst time to try and get a Pringle tape around the hilum. Inflow occlusion can be done, as we've seen earlier by Nilesh. You can use a vascular clamp if you cannot go around the hilum with a tape, but I tend to use an extracorporeal Pringle. You have to have advanced suturing skills. There are no shortcuts to this. If you run into problems with bleeding, stapling is not the answer. You have to have some advanced suturing skills that will help you to control the bleeding. The key principle, however, is minimize blood loss. In a cirrhotic patient or patient with chronic liver disease, you have to minimize the blood loss, otherwise your patient will decompensate after surgery. The newer kid on the block is an ICG camera that will help you guide whether or not there's a tumor or is it a nodule, which is a non-cancerous lesion. The first case I'm going to talk to you about, and important things that I always do in terms of my resections. All my resections are done using an Olympus 3D system with split legs, as shown by Nilesh earlier. I use 5 ports for major hepatectomy, 3 times 12 ports, and 2 times 5. As I said, I always use an extracorporeal Pringle, and we use 10 minutes off, 5 minutes off, 10 minutes on, 5 minutes off. And all my parenchymal transaction is done using a Lotus parenchymal transector, which allows me to use it as a Couser as well, and I'll demonstrate this in the video. Extraction is all done through a fan and steel incision. So the first case is a patient who's a 40-year-old lady who had background hepatitis B, cirrhotic liver, good synthetic function, Child's A, and the tumor sitting on top of the right hepatic vein. So you can see here, this is the first case, and you can see the tumor is sitting bang on top of the right vein as encircled there. And that's the cirrhotic liver that you can see, and you start by mobilizing the liver. And the principles are the same as you would do for any hepatectomy. Once you mobilize the liver, you have to get control of the hilum. I tend to use slings, as you can see the sling on the right hepatic artery, allows you to elevate the structures. And also when you're applying the clips, gives you good traction. So the hepatic artery has been divided here, and now you can see the portal vein is being clearly demarcated and the Hem-o-lok is being applied. Be sure when you apply the Hem-o-loks that you don't get any additional tissue. Now comes the key bit, which is parenchymal transaction. Do this slowly, take your time, because when you rush parenchymal transaction, you will run into bleeding. And you can see here, I'm doing this very slowly. And now you can see I'm using the Lotus as a Couser to identify V5 very clearly. And you can dissect this as exactly as you do with a Couser, both above and below the vessel. And always make sure you clear the parenchyma beyond the structure before you start clipping it, so that if you do run into bleeding, then you can control it much more efficiently. So the transaction, again, it's a slow device, but you can see here now you use a Leahy to go around the V5. And then once you go around the V5, you can use a Hem-o-lok to occlude the blood vessel and then divide in between. So it's a very slow, meticulous process, and it's not worthwhile rushing this. And once you've done the V5, I tend to take the bile duct early. So once you've done the V5, as you can see here, I apply the stapler. Make sure when you apply the stapler, use another instrument to keep the Hem-o-loks out of the way, as you can see there. So it allows for accurate positioning of the stapler on the bile duct. And then you come on to V8. And as you can see here again, I'm using the instrument as a Couser to dissect above and below the V8 to clearly dissect the entire structure before you pass a Leahy and you're able to occlude it using a Hem-o-lok. So next thing I'm going to do is to pass the Leahy, and this is a very safe technique to do. And in a cirrhotic liver, take your time, don't rush it. I cannot emphasize this more. And when you apply the Hem-o-lok, as you can see, I'm half occluding it as I'm entering in there, because otherwise you can catch additional tissue. And then once it locks, you can divide safely in between. And as you then go along the dissect, as you can see here, using a gold finger. And then once this has been divided, then you can proceed to dissecting out the right hepatic vein. And that then completes your resection. The next case is, you can always do a redo hepatectomy in chronic liver disease. This was a patient with a segment 2 HCC, and this was resected and then presented with a further recurrence in segment 3. And you can see here that when you start the transaction or the hepatectomy, you can see the Pringle tape being passed around the hilum, which allows you to get good inflow control. And this is a previous resection, as you can see. And what we're going to do now is a completion left lateral liver resection. Again, in a cirrhotic liver, take your time with the parenchymal transection, do it slowly, do it very carefully and meticulously. This instrument is a slow instrument, but because it's slow, it gives you much more efficient hemostasis and biliostasis. So slower the better. Sometimes people say you want to do a quick transaction. I believe slow is better. And as you can see, you can work your way very slowly, carefully, until you get the outflow. In this case, I've not shown the inflow for sake of time. Our inflow has already been divided. And now you can dissect down onto the left hepatic vein, which you're going to take again on a sling and then divide using a stapling device. So again, when you hold a sling, it allows you to place the stapler much more accurately. So that just completes the transaction once you fire the stapler. So that shows that you can do it in chronic liver disease as well. What about doing a hepatectomy in chronic liver disease and if you run into bleeding? As you can see here, this is a patient who had a tumor in the left lateral segment of the liver, seemingly an easy resection. And I always say this was a resection being done by my very senior trainee, who's a very good consultant now. And he's using a hook, which I hate. And I wanted to demonstrate why the hook is not a good instrument. So you can see here, he's using the hook to do the left triangular ligament. And when he's using the hook, what he inadvertently does is he picks up the hepatic vein, which he doesn't realize. At the moment, it's going well. And then at this point now, I'm going to pause it because you can see he's picked up the vein. He's not realized it. And then he's going to buzz using the monopolar diathermy. And you can see what's going to happen next. There you go. You got a big bleed in the cirrhotic liver. But what he does next is equally important. He places a swab there, does not panic, and waits for assistance where we can get in there. And then I had to put two stitches in this particular patient for the left hepatic vein. Very easily done, and which is why you need advanced lap suturing skills if you're going to take on and do hepatectomies in chronic liver disease. As Nilesh said, there's a scales of hepatectomies you do. And when you get to this stage, it's when you can do all these things without too much difficulty. The important thing to know is bleeding in hepatic venous injury, you have to be very careful. Sometimes you cannot see it because of your pneumoperitoneum being high. So you have to lower the pneumoperitoneum so that you can pick up small ooze before you complete your hemostasis. And then we proceeded to doing the resection. The new thing that's on the block is ICG. This was the third time redo liver resection in somebody with a recurrent HCC on hepatitis B. And you can see the tumor is now delineated very clearly by giving ICG 24 hours before. And again, allows you to mark the tumor very carefully, and you can then do the resection. I'm not going to bore you with the resection because it's a pretty easy resection once you identify the tumor. So the next thing to remember is, could minimal access surgery influence management of HCC treatment? And I think the answer is yes. The more important question is, could the risk of decompensation be lesser if you use this approach? Because there, as we know from other surgeries, there is a reduced metabolic response to trauma. There is a study that's come out. This is the first and only study that has looked at laparoscopic hepatectomy in chronic liver disease. And clearly, this study has shown that with intention to treat, laparoscopy was associated with a lower risk of post-hepatectomy liver failure. And this is evidence enough that we should be proceeding down this route if you're going to not disadvantage our patients with chronic liver disease. So in summary, the decision to resect has to be a multidisciplinary decision. The assessment of synthetic function should be done before you actually proceed to resection. Liver resections in cirrhotics does require a good anatomical assessment and plan for what you're going to do with parenchymal preservation wherever possible. I always, as I say, use extracorporeal Pringle tape for inflow occlusion. Parenchymal transection is the most important bit and should be done meticulously and slowly to minimize blood loss, because that is what is going to reduce your chances of decompensation. An early detection of decompensation is important in patients with chronic liver disease. And we know now there is evidence that minimal access approach is associated with a lower risk of post-hepatectomy liver failure. Important thing, build a team. This was my team in Leeds, and this is my team at King's. Good teams give you good outcomes. So always have